So our next speaker is Dr. Julia Critchley from St. George's, University of London. She's worked for many years in cardiovascular disease, diabetes epidemiology, and public health. And for the past 10 years, her research programs have focused on the association between common chronic and infectious diseases such as diabetes and TB, and that's what she's going to talk about today. And here's the clicker. This should be forward. Yes. Okay. And there's a laser there also.
Thank you very much for the invitation to speak this afternoon. I'm going to talk about diabetes and then TB. And unlike perhaps most of the previous presenters, I'm going to talk about this very much from an epidemiological and a population health perspective. I'm not an immunologist, okay? So I'm going to talk about mainly the strength of the evidence for associations, why we think this is a problem from a global public health point of view, and also what can and perhaps what should we be doing about it. Okay, so I've just got a couple of slides here that give you a very broad brush introduction to the global burden of TB and diabetes that help to highlight the actual problem. So we know that TB is still the leading infectious cause of mortality globally, about 1.7 million deaths annually, 10.4 million active TB disease cases annually. And we know that about a quarter of the global population is likely to be infected with latent TB, LTBI. In terms of diabetes prevalence, about 1 in 11 adults, that's 425 million people globally, are thought to have diabetes, mostly type 2 diabetes. In low and middle income countries, many of those people are not diagnosed. They don't know that they have diabetes. The IDF Diabetes Atlas predicts that this number of people living with diabetes will increase to 629 million or so over the next few decades, about 1 in 10 adults, if you like. So this is essentially a very huge epidemic. We know why diabetes is increasing in terms of the risk factors. They were mentioned by one of the earlier presenters, changes in urbanization, changing lifestyles, reductions in physical activity, less healthy diets, and particularly large increases in obesity have been occurring in most parts of the world. However, what is less often mentioned is that a lot of this predicted rise in diabetes over the next few decades is simply due to population aging. Populations are getting older all over the world, particularly in Asia, where diabetes is common. So even if we found some way of reducing obesity, we wouldn't be having a big impact on this future burden. There's going to be a lot of people with diabetes over the next few decades. And just to highlight this point further, this again comes from the Diabetes Atlas. It's the regions of the world that have the largest predicted increase in diabetes burden over the next few decades. What I hope is immediately obvious, or maybe it would help if I could work the pointer, is that the regions of the world where diabetes is predicted to increase the most, sub-Saharan Africa, albeit from a lower starting level, Southeast Asia, are also the regions where TB is endemic. So for these reasons on their own, we're particularly concerned about associations between diabetes and TB. Now, historically, an association has been noticed. In the past, diabetes was often actually diagnosed with some signal infection, some unusual infection like mucormycosis. The extract on the right was published in 1694 in my home city, London, talked about consumption, TB, and sugary blood. In the 1950s in the UK, joint treatment for TB and diabetes was actually given in specially set up clinics for joint treatment around Birmingham. Now, these seemed to disappear after the 1950s, I think because that was around the time when newer drugs for both conditions were introduced. So the kind of problem in terms of the high death rate substantially dissipated. However, there's been more interest in this association again in the last few decades as diabetes burdens have risen a lot in low and middle income countries. Recently updated reviews have tried to actually summarize the strength of the association between diabetes and risk of developing active TB disease. So this is the most recent, 44 studies, 16 countries. They're mostly observational studies, prospective cohorts, case control studies, and they find about a doubling of the risk of TB for someone with diabetes. So of course this association is not as powerful as HIV and TB, but because so many people are living with diabetes, we think it's likely to be important at a population level. And in the better designed studies as well, prospective cohort studies, the association was, if anything, stronger, and again, slightly stronger in low-income, high TB incidence studies and in Asia, and in the studies with better case definitions, microbiological confirmation of TB, and blood glucose or HbA1c testing for diabetes. So that moves me on to think about hyperglycemia and TB risk and TB treatment outcomes. So really, would improving glycemic control have any impact? And there's quite limited evidence here. There are perhaps some suggestions from these studies that there may be higher TB risk with poorly controlled diabetes, but this is observational data. There aren't any randomized controlled trials that have looked at this question. And indeed, even the classic trials of diabetes control, only one of those actually really reported on any infections as an outcome, DCCT and EuroEDIC, although it did find some suggestions of reductions in risk of infections with better glycemic control. So we think glycemic control might be helpful, but we don't have much direct evidence. Now, this slide here comes from English primary care data. You might make the point, which is very reasonable, that this is not the ideal population to consider TB and diabetes. But as was mentioned by Dr. Naveen earlier, I'm lucky to live in a country with good access to data. So this is what we were able to do. What this does show is a very non-linear association between diabetes glycemic control, that's HbA1c measurements on the x-axis, and risk of serious infections up here, particularly once diabetes glycemic control HbA1c gets above about 9 millimoles per litre. And even in the UK, where we don't have a huge amount of TB, except in London, we reckoned that statistically about a quarter of TB amongst diabetes patients could be statistically attributable to the poor glycemic control. So that's interesting, doesn't prove that better glycemic control would help though. TB treatment outcomes amongst those with diabetes, again, there have been a number of systematic reviews, and a very large number of studies, in fact, 102 in total in the most recent review. 44 of those actually reported on mortality, which is where I think the evidence is therefore strongest. By and large, the meta-analysis suggests that the risk of a poor treatment outcome or these individual treatment outcomes, death, relapse, are roughly doubled for someone with diabetes compared to a TB patient without diabetes. And again, the probably better designed and analysed studies that at least could adjust for key epidemiological confounders tended to show a higher risk, if anything. MDR-TB is not specifically a TB treatment outcome, but of course any increase in that would also be of huge concern. So we know that diabetes is very common in TB patients. It's common in adults generally. And a recent meta-analysis actually pulled together all the data sources, suggesting overall about 15% of TB patients have diabetes. So this is high. But note, there's a lot of variation across studies and a lot of heterogeneity between studies. There are certainly hotspots where there seem to be particularly high prevalence of diabetes in TB patients. India, Pacific, Texas-Mexico border, for example. But there are studies that I'm aware of from sub-Saharan Africa that have not yet identified a lot of diabetes in TB patients. So can we diagnose or screen for diabetes in TB patients? This work comes from the Tandem Consortium that I was a part of. We tried to consider how easily we could diagnose diabetes in TB patients, considering that diabetes is often undiagnosed. And again, what you should see here is heterogeneity across the 4 populations. So certainly it is possible to develop screening strategies that can help detect diabetes in TB patients, but it's more difficult in some populations than in others. In some of our populations, what we seem to be identifying was a lot of people with stress hyperglycemia, raises in blood glucose or HbA1c associated with the infection, not necessarily diabetes, although it may develop into diabetes in the future. If we had the longitudinal follow-up, we could look at that, but we don't. So there's uncertainty and heterogeneity there as well. However, earlier a comment was made about simplicity. This takes forward the work that was started by the Collaborative Framework for TB and Diabetes in 2011. Quite recently, they've reported some guidance which is aimed to be simple and practical. It's being tested and aimed at frontline healthcare workers in low and middle-income countries, and it makes suggestions about how to screen, what drugs to use, levels of glycemic control, when you might need to involve diabetes services, for example. So it's there, and it's there to be used and evaluated. My last couple of slides, I'm just going to move back to what I'm interested in particularly, which is the population impact. This is some work I've been doing with a group of mathematical modelers. I haven't shown you big pages of differential equations for obvious reasons, but the mathematical models attempt to look at the impact of diabetes on TB at a population level. So it's not just people with diabetes that might be affected, because people with diabetes, of course, can also transmit TB to other people in their communities, friends, relatives, families, who don't necessarily have diabetes. So what we did was we looked initially at the trends and the predictions for diabetes prevalence in India. This is data from the IDF and from national surveys and elsewhere, and how that's changing over time. And we developed a conceptual framework that tries to take into account all the pathways mentioned previously by which diabetes might be affecting TB. So what's the bottom line here? Well, at the beginning of the time period, we were interested in probably not a huge proportion of TB-related mortality or incidence was statistically attributable to diabetes in India. But as diabetes prevalence rises, and TB incidence and perhaps other causes of TB start to decline, we do suggest that that proportion that's statistically attributable to diabetes is likely to increase very dramatically over the next few decades. I would be the first to accept there is considerable uncertainty in these estimates, but you can see that they're very high. 40% of deaths and about a third of incidence could be attributable to diabetes by the year 2050 in India. Okay, so finally, my conclusions. I think we can be very confident, based on the observational evidence, that diabetes does increase the risk of active TB disease, even if we don't know the precise mechanisms by which it may do so. And it also increases the risk of at least some poor TB treatment outcomes, particularly mortality. Diabetes is clearly quite common in TB patients, and it's often undiagnosed. Higher glucose and HbA1c levels may be associated with higher risks of developing TB and also having poorer TB treatment outcomes, but we don't have direct evidence to the extent to which we can reverse that at present. This is the kind of summary, and where the field has been coming from is that we may well need better screening and clinical management of TB and diabetes. Generally, screening TB patients for diabetes has been quite well accepted by most bodies, WHO, IUA-LTD, and WL Diabetes Federation, but there's less evidence for more uncertainty around any benefits from screening diabetes for TB. Active TB disease, screening diabetes patients for active TB disease. So that has been tried in some places. We need simple and cost-effective screening algorithms, and we need to bear in mind that any screening may well need to be repeated as well because of infection-related stress hyperglycemia. But one of my biggest concerns is what actually happens to patients identified with diabetes at the end of TB treatment. TB treatment is relatively more accessible. It may be possible to actually identify undiagnosed diabetes during TB treatment, but we know in many parts of the world that diabetes services are much harder to access. They may be simply too expensive or not of particularly high quality in terms of the public services. And there are as yet no longitudinal follow-up. Essentially, we need to move from disease towards health. We're only really helping people if we can actually manage their diabetes better after the end of TB treatment. From a population impact, we think that in some populations, and we've used India as a case study, the population impact could be very large. 1 in 3 cases could be potentially attributed to diabetes in the future, 1 in every 3 TB cases. However, we also know that screening and managing diabetes during TB care will not have a big impact on that overall burden. I took that slide out to save time, but essentially it will have less than a 1% impact overall. However, if we move further upstream and we can design any strategies that actually have an impact on people with diabetes before they develop active TB, or better still, even further back on the risk of developing diabetes and more severe hyperglycemia, you can have a much bigger impact of maybe reducing the burden by 20 to 30% or more. There are many heterogeneities here that I haven't fully acknowledged, but that's my final point on the slide there, that this is obviously very broad brush. I want to thank many people, the funders, the mathematical modelers that I've worked with in Qatar, the EU, and all the people that have collected data as part of the Tandem Consortium. Thank you.